Assalamu alaikum wa rahmatullah. I am Dr. Ahmed D. Abdulwahab. I am a radiologist working in Erbil, Razgari, and today we will be talking about X-ray of musculoskeletal trauma for beginners. As the name implies, we will talk about X-ray of musculoskeletal trauma, that's fractures and all kinds of traumas, and we will be talking about it for the beginners, like basic level. We will not take the whole thing. Okay, we will not take about complex things and things like that. So I just have to arrange this Zoom thing. I'm sorry, I'm not very expert in using the Zoom. Just give me a second and we will start very soon. Okay, I just want to minimize that. Excellent, good job. So we will talk about, as we said, X-ray for the musculoskeletal trauma for beginners, and we will start from the beginning. I will talk about generally about trauma and different kinds of fractures and fracture nomenclature and how proper description of fractures today, and the talk is big and we will not be able to finish it today, so we will continue with our talk tomorrow, I hope, and I will send you the invitation link for the tomorrow event. Will be at 7 p.m. Okay, so now let's see. And what's going on? Okay, regarding trauma. So trauma, what is the X-ray appearances of fractures? Trauma is the most common cause of fracture. I want to first start by describing what is the X-ray appearance of fractures. What does fracture appear like on an X-ray? In most cases, the fracture is just, there is a line of lucency, a dense line, a dark line or a darkish line that separates two different pieces of the same bone. The same bone gets fractured during its course, and it's usually seen as a dark line or a lucent line. However, sometimes, of course, when there is a fracture, the bone pieces will either separate from each other or they will angulate, or both separate and angulate. We will talk about that in details in a few minutes. So, first of all, we can see, for example, this is a fracture of the humerus. You can see the two bone pieces are separated from each other by a dark line. You can see the dark line here in the orange color, indicating this bone is fractured, and you can see the fracture is angulated and shifted, and we will talk about this in a minute. So sometimes the fracture fragments are not separated, or sometimes the separation is obscured by the angle of the projection, of the image projection. It might separate the fractured fragment. So if they are not separated from each other, okay, it's called impacted. The fracture is impacted. Or if they are overlapped and the and the projection shows that these two pieces are over each other, there will be no lucent line, no dark line. There will be dense line. There will be a line of increased density. And the fracture is usually, can be, if it is a subtle fracture, it can be as in the form of a step in the bony cortex. So you need to follow the bony cortex all around, or all around the bone, to look for if there is any step in it, or if there is any interruption or discontinuity. And as we said, if there is a band of increased density, indicates the bone either impacted, not separated from each other, compressed with each other, or they are overlapped with each other. Okay? So sometimes the projection can hide the fracture from us. That's why we need always to have at least two views of the same side to rule out fracture or to have more detailed description of the fracture. We need two two views of the same bone, of the same part. Okay, so now let's see. For example, here you can see, if you look rapidly, there might be nothing to be commenting on, but if you look carefully, you can see there is a tiny step here in the bone, and there is a very faint lucent line, dark line, separating the radial styloid process from the rest of the bone, and this is a non-displaced fracture with only very thin line. Okay, another example of how subtle a fracture can be. If you look here, it looks basically normal. However, if you followed the bony cortex all along its length, you can see that there is a step here, or just a tiny step. You can see here outlined in the yellow color. So this is a fractured head of the radius, and it's very subtle. It might not be easily seen on one projection. You might need two or more projections to see it. Another example of impacted fracture we can see in this X-ray of the hip joint, the left hip joint. You can see there is a line of increased density at the level of the femoral neck, and the two bones are impacted with each other. Instead of lucent line like we saw previously, there is a dense line, an increased density line, and this indicates a fracture. And if we look at the bony cortex, just here there is a small step, and at the other side there is also a tiny step at the femoral neck, indicating fracture. You can see it here outlined in the yellow color and the impacted part. Okay, another example of a fractured fragment that is so subtle, you can see in this ankle X-ray showing a very thin linear lucent line, which might be mistaken for a growth plate. However, if you look carefully, you can see that the overlying soft tissue is markedly swollen and edematous. Okay, so this swelling and edema gives you a hint that this is not a normal finding. This is just a fracture line that is simple and non-displaced. So the most important thing to be sure that there is a fracture, and at least to look for where is the fracture, is one thing only, that is ask your patient, where does it hurt? Where is the pain? 100% of the time, the patient will show you exactly where to look for the fracture. In this case, of course, there will be the lateral malleolar region, and if you look carefully, you can see the fracture line. So now we saw that this patient has a fracture, and the fracture is in that bone. How to describe it? What are the parts to report when we are seeing a fracture? First of all modern references says that advise us to we should not use the names of the fracture. We should not say this is a Colles fracture, or this is a Dancer fracture, or this is I don't know what fracture. Don't use these names, because you do not guarantee that the person or the physician whom you are referring the patient to knows what is Colles fracture. We might know it, but we cannot say that the other person knows what is the Colles fracture means, for example. So we need to describe it anatomically, not by name. So how do we do that? First of all, we have to say which bone is fractured. What is the name of the bone that is fractured? And we should say if it is the right or the left side. The right humerus, left humerus, right femur, left femur. And we should make sure that on the film, on the X-ray film, always has a right, an R or an L. And if it doesn't, don't let this go by. We should either do another X-ray to make sure, or you have to see the patient and make sure that the right humerus is imaged, not the left, or vice versa. So we should have an R or an L letter, reference letter on the image to be sure which side is fractured, because the report, as much as you can be careful, but you might lose. Sometimes you might make some mistake. So now we know that the femur is broken. Which part of the femur is broken? Is it the diaphysis, the metaphysis, the epiphysis? And it's also important to note whether the fracture involved the articular surface or not. Is the fracture is extending into the articular surface of the bone, extending into the joint or not? This is an important thing to mention. So we should say that there is a fracture in the diaphysis of the left femur, okay, or the metaphysis of the left femur, and the fracture is extending into the articular surface of the medial femoral condyle. The articular surface extension is important because if the smooth articular surface, the smoothness is lost due to the fracture, the step of the fracture, this will require a different kind of surgery and very accurate reduction, because this roughness in the articular surface due to the fracture will result in long-term osteoarthritic changes. The joint surface will become rough and the patient will have a lot of suffering in the future. So we should be exact whether it is extending to the fracture line or not. And we should be careful about the number of the fractured fragments. If there are two pieces only, this is a simple fracture. If there are more than two pieces, this is a comminuted fracture. Doesn't matter whether there are 3 pieces or 12 pieces. If it is more than 3 or more, it is a comminuted fracture. So we should say that there is a fracture at the metaphysis of the left femur, extending to the articular surface. It is a simple fracture, that's 2 pieces, or comminuted fracture if it is more than 2 pieces. And what else should we mention in the report? We should mention the orientation of the fracture. What does the fracture, what's the plane of the fracture? Is it transverse? Is it longitudinal? Or is it oblique? Or if there is a twisting force, it can be spiral. So there is a longitudinal fracture in the or transverse fracture in the left femoral metaphysis extending to the articular surface. It's a simple fracture. There are 2 pieces. The next step to describe, other than the orientation, is the displacement. This is very important thing to describe. Is the fragments are displaced from each other or not? And here I want you to keep in mind the following. Always describe related to the distal part of the fractured bone. Always the distal part. Don't comment on the proximal part. The distal part is the one that we describe. Okay? And we should determine how the alignment of the fractured fragments has changed from the normal anatomy. That means, has it moved away or towards? Okay? And is it angulated, shifted, or combined? So, if it's angulated, what type of angulation? If it's shifted, what type of shift? The displacement of the fractured fragment can take the form of either angulation, shift, or combination of them. The angulation can occur, the angulation we said angulated laterally, medially, anteriorly, or posteriorly. Okay? The shift is either proximal shift or distal shift. Okay? So, in order to be accurate with that, we need 2 views at 90 angles to each other. So we should say the fractured fragments are angulated, the distal fragment is angulated laterally, okay, and it's shifted proximally, and preferably to be shifted to report that it's shifted by 1 centimeter, by 2 centimeter, by half centimeter. How much the shifting should be also reported. The other thing related to displacement is to report whether there is a dislocation or not regarding the joint. So the dislocation, what does it mean? It means the 2 articular surfaces are not in contact with each other. They are separated from each other. While subluxation, the articular surfaces are partially in contact with each other, not completely lost contact. So we should say if there is a dislocation, it's dislocation. If there's a joint affection, whether it is dislocation or subluxation, it's different. And always we describe the position of the distal part of the joint. For example, at the glenohumeral joint, we describe the movement, the change in position of the femoral, of the humeral head. We say there is an anterior dislocation or a posterior dislocation. You don't comment on the glenoid process. You comment on the distal part of the joint. That is the humeral head. Is it anteriorly dislocated or posteriorly dislocated? Okay. And usually the name of the distal bone, usually it's omitted. You don't say there is anterior dislocation of the humeral head. You say there is an anterior dislocation of the shoulder joint. Okay, you omit the name of the bone. So I don't know, till now is it okay for everyone? If you can write in the comment section in the chat part. Everyone is hearing me loud and clear?
Yes.
I hope so. So, good. What are the other signs of joint injury that we need to look for? I'm talking about joint now, not the bone, the joint. So, other signs to look for are the following. Just a second. At certain joints, you can look for intra-articular swelling. Intra-articular swelling is not a pathology by itself, but it indicates that there is a significant joint injury. Normally, for example, at the knee joint, suprapatellar pouch, normally it is thin structure. When the joint is swollen, there is joint effusion, the thickness of the suprapatellar pouch gets increased, okay? Sometimes due to fluid, simple fluid, sometimes due to blood, hemarthrosis, or sometimes even due to fat from the bone marrow. If the fracture is extending into the articular surface, the bone marrow will leak into the joint and will cause blood fat level, that is lipohemarthrosis, that's called. Okay? What else? And we need to see the two layers using the lateral X-ray. Lateral X-ray, we'll see example of that in a minute, to detect the lipohemarthrosis level. And lipohemarthrosis can be seen in about 1/3 of intra-articular fractures of the knee. The other 2/3 just have simple hemarthrosis. Okay, so other X-ray signs of joint injury. On the lateral view of the ankle, sometimes we can see the swelling extending anteriorly from the joint. I'm talking about lateral view. Swelling at the elbow is slightly different in that we are looking for the fat pad. The fat pads are within the joint, and when there is a joint effusion, the fat pad will be elevated, and this is called the anterior and posterior fat pad sign. The thing I want you to know is that the anterior fat pad is normally there, but it's concave. When it's convex, there is something wrong. There is joint effusion. The posterior fat pad usually very thin, or usually it cannot be seen. So if you see the posterior fat pad, there is something wrong. You should not be able to see it, and we will see an example about that. For example, let's look at this hand X-ray now. What do we have here? We have a fracture. Fracture where? At the first, second, third metacarpal bone. Where at of the right side? So there is a right hand fracture of the third metatarsal bone at the region of the proximal diaphysis. The fractured fragment, now we'll talk about the distal part of the fractured fragment. The distal part is shifted proximally by about 1 centimeter, and it is displaced medially, okay? And the fractured fragments are overlapped each other. However, this is one view. We need at least two views to be sure, and they are overlapped with each other. One thing to notice, to be aware of when describing the shifting. The shifting, we always describe it not by 0.5 centimeter or 1 centimeter, no. You describe the shifting by how many bone lengths they are separated. This is the original bone, and now it is shifted by entire bone length. Now it is shifted by half bone width, sorry, by half bone width, by third bone width. You just estimate how much the bone is shifted. So you determine the shifting by the width of the shaft of the bone. I hope it's obvious, you can understand. So, for example, here it is shifted by about half bone length. How much of the bone is, of the diameter of the diaphysis of the bone is shifted? So, for example, if it's big bone, like for example femur, this displacement is half bone width. While if it's a small bone like the metacarpal here, this is a half bone width. This is a full bone width. Okay. At the end we will have few minutes for maybe answer questions and discussions and things like that. Okay. Now let's see if the fractured fragment extends into the articular surface. For example, here you can see that the fracture is extending nice. I think we'll have more time. It's a gift from Zoom. We thank them for that. So we can see that here the fracture is extending into the articular surface. This is a very important thing to describe. The fractured fragment here, it's displaced posteriorly and shifted proximally. This is a lateral view of the finger, and extending into the proximal interphalangeal joint. This is the proximal phalanx and the middle phalanx. Okay, and with overlapping soft tissue swelling. Now let's see a more complicated fracture, a comminuted fracture. What's a comminuted fracture? If you remember, we said it is more than 3 pieces. So there are multiple pieces of this, of the distal. There is a comminuted fracture involving the distal metaphysis of the right femur with more. We said comminuted fracture. We mean multiple pieces, more than 2, at least 3 pieces, and the pieces are displaced from the original their original alignment. Now, another kind of fracture. Let's see here. This fracture, orientation of the fracture is longitudinal. There is a longitudinal fracture. You can see there is this tiny step here, and there is a lucent line that branches into the shaft or the diaphysis of the proximal phalanx of the fifth finger here, the little finger, and you can see that the fracture is longitudinal. This is a longitudinal fracture. Okay. Now, another kind of simple fracture that is showing some slight displacement but no obvious angulation in this view. We need 2 views to be sure there is no angulation, and we'll show an example of that in a second. You can see there is an oblique fracture through the distal diaphysis of the tibia. Okay, this is the right, but there is no R letter, so we should be careful with that. So the fractured fragment, the distal part, is shifted proximally, okay, and is displaced laterally. Okay, how much displacement here? It's about 1/4 to 1/3 bone width. Okay, this distance is 1/4, maybe 1/3 of the width of the tibia. Okay. Now, how does it differ from this kind of fracture? This is a spiral fracture. This has a twisting injury resulting in this sort of spiraling kind of a fracture. There is minimal displacement and no obvious angulation. However, there is another fracture here at the fibula, if you see it here, and this is due to the twisting injuries injuring both bones at different sites. Now, as I said several times, you need at least 2 views to be sure that there is no fracture, or if you see the fracture on one view, you need another second view to comment on the angulation and the shift of the fracture and things like that. So this is a very nice example here. At this image here, you can see that basically there is no obvious fracture or any dislocation or anything like that. The finger looks Very nice. However, if you took the 90-degree angle, lateral view, you can see there is a huge, very big dislocation. The middle phalanx is dislocated posteriorly or dorsally relative to the proximal phalanx, and we always comment on the distal one. So there is a posterior or dorsal dislocation of the middle phalanx. Okay, and if you look even more carefully, you can see a tiny piece of bone here, indicating this is a small fractured fragment, or what's called a avulsed fragment, and we will talk about that in a few minutes. Now, let's see another example of the importance of having two views. This here, we can see there is an obvious fracture here, and of the distal radial metaphysis, diametaphysis, and the fracture fragment is displaced. Okay, it is displaced laterally. It's displaced laterally by about 1/5 of bone width. 1/5 of the bone width is displaced laterally. And if you take the other view, the lateral view, I mean, you can see there is also about 1/2 bone width displacement or dorsally, and some mild shift proximally. The distal fragment is shifted proximally, and so here we have a full evaluation of the fractured fragment. There is the angulation and the shift and the displacement. All of them are seen in two views. Another kind of now we'll show some examples of the dislocation that we talked about previously a few minutes ago. You can see here that the articular surface of the humerus, the distal humerus, is completely separated from both the radius and the ulna. And the radius and the, do we say here there is an anterior dislocation of the elbow joint? No, that is wrong. We say that there is a posterior dislocation of the elbow joint, because we always comment on the distal part. The distal part is dislocated dorsally, and you don't say anterior. There's a posterior dislocation of the elbow joint. Okay. Here we talked about the knee joint the knee joint injuries and the joint effusion and things like that, and we said about the suprapatellar pouch. Normally it's very thin. You can see this, the outlined part here, this tiny line. This is the normal suprapatellar pouch. It's barely visible. It should be not more than 2, maybe 3 millimeter in thickness. Now, where there is an injury that's extending to the joint, there will be joint effusion, which is mostly, if there is a fracture, it will be a hemarthrosis or lipohemarthrosis. So, when there is some abnormality, you can see the suprapatellar pouch is now much thicker. It's more prominent, and this is a clue that there is something significant going on, extending into the joint surface, causing joint effusion, mostly because there's the increased density. In this case, mostly it will be hemarthrosis. So, what about lipohemarthrosis? Let's see here, lipohemarthrosis, we always see it on lateral views. Lateral view of the knee joint, you can see that this is the suprapatellar pouch. Here it's distended, and you can see here this is fat density and this is soft tissue density or fluid density, and they are forming a level here. This is fat fluid level indicating lipohemarthrosis. Lipohemarthrosis necessarily indicates that there is a fracture, and the fracture is extending into the articular surface. So you can see here that the fracture is extending into the articular surface. This is the fracture line. It's very tiny, very thin, hypodense line extending into the articular surface of the tibia, and this causes the bone marrow to leak into the joint, causing this lipohemarthrosis level. Also, we talked about the ankle joint. We said sometimes we can see an increased thickness anterior to the joint, like we see here. This part here, it's swollen due to the joint effusion causing this increased density here. You can see it here outlined, and this is a normal ankle joint just to see the difference. This is a fat, and there is no signs of this bulging or the pouch that is seen here, and this indicates joint effusion, probably to some sort of trauma. Especially with history of trauma, we should be careful looking for any possible fracture. Sometimes we see it, sometimes we don't. Now, what about the elbow joint? We talked about the anterior and posterior fat pads. Now, let's see first the normal part. This is the normal elbow joint. You can see the anterior fat pad is visible, it's thin, and it is concave. It's always concave, okay? The posterior fat pad is either barely visible or not visible at all. So, when we see that the anterior fat pad is convex, like here, you can see this anterior fat pad is convex. And obviously, you can see the posterior fat pad. It's much easier to see than here. This indicates the presence of joint effusion, which indicates the presence of a significant trauma. And if you look carefully within the anterior fat pad, you can even see a fat fluid level, indicating lipohemarthrosis. Okay? Indicating what? Lipohemarthrosis. Okay? So we should be careful in looking for other projections, looking for any possible subtle fracture. There is something called osteochondral fracture. What does it mean? Osteo means bone, chondral means cartilage. So it's a fracture that involves the articular cartilage and the underlying bone. The articular cartilage and the underlying bone, both of them are fractured. It's fracture of part of the joint surface. So usually it occurs when one part of the joint impacts against the opposite part. They just impact against each other, causing osteochondral fracture. Here you should be careful to look for the following. The fractured bony fragment of the articular cortex, the cortex that is of the bone that is fractured, you should look for the following. The fragment can be displaced from, can be undisplaced, it can be still in its place, or can be displaced and lying far away from its original site. For example, in the knee, it can be seen at the lateral or medial recesses, or in the suprapatellar pouch, suprapatellar bursa. It can be anywhere. Okay. The thing here to keep that in this point in mind, and I will come back to it later. Osteochondral fracture, it has always a smooth surface and a rough surface. Smooth surface and rough surface. Why? The smooth surface is the part that is covered by cartilage, the normal part of the bone. Smooth. The cartilage and the joint surface is smooth. While the rough part is the fractured part that is displaced from its original bone. So there is a smooth surface and a rough surface, and this is important, and I will tell you why when we discuss that in a few minutes. So we should make a careful search for any displaced intra-articular fragment or any defect in the articular cortex of the joint. Okay? For example, let's see this example of the ankle X-ray. You can see here there is a tiny bit of bone, and this tiny bit just matches the missing part of the talar dome. It's displaced, not far away, but still it's displaced. And if you look very carefully, you can see that this part is a little bit rough, while this part is a little bit, it's more smoother, because this is the normal part of, it's just like here, smooth, while this the part that is displaced from the bone, it's rough. And we'll say why is that important in a while. So in any ankle joint trauma, you should look carefully at any defect at the ankle dome, and it can be easily missed on an X-ray. In fact, only 1/3 of the fractures, only 2/3 of the fractures are visible on the X-ray. 1/3 they are not visible on an X-ray, and they are missed. Okay, so usually there is 1/3 of the fractures not visible on the X-ray, and they can be missed. So we should be very careful not to miss that. Now, what about avulsion fracture? Avulsion fracture, it's a fracture when, just a second, sorry. It's a fracture when there is sufficient tension, sufficient traction, sufficient force to pull something that's attached to bone from its bony attachment, taking a piece of the bone with it. When there is sufficient traction, sufficient force, either the soft tissue or the structure will rip apart, will rupture, or it will pull part of the bone with it. That said, the part that is susceptible to avulsion fracture can be seen at the insertion of ligaments, tendons, muscle, or joint capsule. There is something that's not bone attached to the bone. Sufficient force will either rip the ligament, the tendon is ruptured, or the muscle is ruptured, or it might pull a part of the bone with it. Tiny piece, that's called avulsion fracture. So let's see now. Here in this X-ray, you can see that there is an avulsion fracture. There is a fragment. This fragment that's colored green. It's an avulsion fracture caused by at the site of the attachment of the ACL. So the anterior cruciate ligament is causing an avulsion fracture at the tibial cortex of the tibial eminence or tibial spine. It's avulsed. It is the site of attachment of the anterior cruciate ligament here. However, if you look very carefully, you can see a tiny piece of bone just at the lateral aspect of the tibia, and this piece has a smooth outer surface and a rough inner surface. This tiny piece is an avulsion fracture of the lateral collateral ligament. The lateral collateral ligament underwent sufficient traction to pull a part of the bony cortex with it. Okay, although it's small piece, it looks innocent, but it has a strong association with ACL and meniscal tears. This kind of fracture is traditionally called second fracture. However, I would not recommend you to use these terms without proper description. Say there is a second fracture manifesting as an avulsed bony fragment of the lateral side of the tibial epicondyle with minimal displacement. Describe the fracture in details. Don't just say there is a second fracture. It's not enough. This might be insufficient for the treating physician or the orthopedist. Other kinds of fracture are stress fracture or insufficiency fractures. These fractures occurs when repetitive force is applied to a bone. What's the difference between stress and insufficiency fracture? If there is an abnormal high repeated force, there is force that is repeated with normal bone, the bone is normal, resulting at the end or in a fracture, this is called stress fracture. So stress fracture, it is repeated force on a normal bone. However, there is normal force, normal tolerable force on an abnormal bone that is weak, resulting in a fracture. This is called insufficiency fracture or fragility fracture. So abnormal force on a normal bone is stress fracture. Normal force on an abnormal bone, it's insufficiency fracture. Okay? Insufficiency fracture, most of the times it's seen in patients with osteoporosis. The bone is weak. Okay. Now, let's see. One thing to say before we go to the next image. Here, for insufficiency fracture or insufficiency fracture, you don't see like a frank fracture line. You just see its effect. And how is that? First, the patient complains of pain at this specific site, okay? And you take an X-ray, there is no fracture line. There's callus formation. You can see here, there's a callus formation on a patient. There is, the callus formation indicates that there is a fracture. If there is a repeated force on a normal bone, then this is a stress fracture. If it is abnormal bone, there is insufficiency fracture. Just by looking at it, you can see that there is no signs of osteopenia. The bone is dense enough. So this indicates this is a stress fracture. You should look for any abnormal, high, repeatable force in the patient's history. Now, one more kind of fracture is a pathological fracture. What does it mean, pathological fracture? It's a fracture caused by a focal lesion in the bone that is causing weakening of the structure of the bone. There is a lesion that is destroying the bone, resulting in its weakness. Most of the times, it's due to metastasis. Not always, but the vast majority is due to metastasis, resulting in fracture of the bone due to destruction of the bone. So, for example, here you can see this vertebra and this vertebra are collapsed, they are fractured, they are compressed with each other, and there is no history of sufficient trauma to cause vertebral body fracture, possibly with a history of primary malignancy. So this should be considered as vertebral body metastasis till proven otherwise. Now let's see another more obvious example. You can see here there is a fracture line here and another fracture line here at the inferior pubic ramus and the ischium, and between the ischium and the ischial bone. So if you look carefully, you can see that this bone is not healthy. It's not normal bone. It's a destructed bone here, and here the bone is moth-eaten. Just compare this bone with this bone. This is a normal bone. This is a normal bone. This is a normal bone. Here this bone is moth-eaten. It's destructed bone. So this indicates that here there is a pathological fracture due to metastasis. Whenever you see this appearance of a moth-eaten bone, it's weak, it is possible to get injured. Now, the important thing to be careful about regarding all the previous kinds of fracture is to know what is not a fracture, what kind of abnormality that might look like a fracture but it's not. First, you should look for any accessory ossicle. They are characteristically round, small, and adjacent to a joint, and they differ. This is the point that I want you to know. They differ from the osteochondral fracture in that they have all smooth surface all around. They don't have smooth on one part and rough on the other. It's smooth all around, okay? So this is how to differentiate the accessory ossicle from an osteochondral fracture, okay? In addition, you should know your anatomy and you should know where the accessory ossicles are commonly present. And the third important thing, accessory ossicles are not associated with pain. If you ask your patient where does it hurt, he will not tell you the site of the accessory ossicle. He will tell you something else in most of the times, unless there is another fracture at the site of the accessory ossicle, which is very unlikely. So, for example, let's see here. You can see that there is a soft tissue thickening and swelling here over the lateral malleolus, while here there is a fractured fragment. So is it possible that we have edema and swelling here with a fracture here? Of course, this doesn't make any sense. If you look carefully at the fracture at this bone fragment, you can see that it has a smooth cortex and smooth outline on both surfaces, indicating that this is just an accessory ossicle. Another thing that might look like a fracture is a skin crease. Sometimes a skin crease can appear as a hypodense or lucent line extending across the bone, resulting in appearance looking like a fracture. However, if you follow the hypodense line, you'll see it passing behind the bone, after the bone, and this indicates that the fracture, that it is not a fracture, it's just a skin crease. For example, you can see here there is a lucent line extending across the trochanter, the greater trochanter of the left femur, and there is another one here, and there is another one here, and there is another one here. If you follow the lucent line, you can see it extending beyond the bone, and of course it cannot be a fracture extending beyond the bone. So I think for the types of the fracture and the alignment of the fracture and the orientation and description of the fracture, we covered a very big part, and I think we will stop here today, and we might continue tomorrow, inshallah. We will continue tomorrow at 7 p.m. We will start with dealing with specific injuries like shoulder joint injury, all kinds of joint injuries. shoulder joint, hip joint, knee joint, specific kinds of injuries, and we will talk about them tomorrow. Thank you for listening. If anyone has any comment, I will open the mic now and I will answer your questions.
Recording stopped.
Thank you very much.